one of the sessions of this meeting, we have discussed about the optimal treatment at the time of the relapse. And now we have many options available. We have many combinations that are approved. We have different possibilities with carfilzomib available, with lenalidomide, with pomalidomide, with monoclonal antibodies such as daratumumab available. And these drugs, these classes of agents can be combined at the time of the first relapse, second relapse, or in very advanced disease. So the most important issue now is to try to define the optimal sequence of treatment. And we know that at the time of the first relapse, we have to take into account what was the first line option for the patient, the front line treatment. And then it is becoming more and more difficult to define, that's a big challenge, to define the optimal option at the time of the first relapse. And we know that more and more patients are now receiving frontline lenalidomide, not only young patients receiving len maintenance after stem cell transplantation, but also elderly patients that are receiving lendex until progression. And then in Europe, the majority of the patients are going to progress on lenalidomide. So we discussed about the best options in this setting. We have, for example, KD available, carfildex, that is better than bortezomib-dex, superior to VD. We also have VD plus daratumumab based on the results of the CASTOR study. But these two combinations are not optimal. So we discussed about the results of the optimism study looking at VD plus pomalidomide with pretty good results. So we have to take into account a logical approach. We are switching of class. Efficacy matters for sure, but also toxicity, quality of life, cost, drug access, and also patient's choice. That's very important to be able to explain to the patients what are the goals of the treatment. And we also have to look at the burden to the healthcare system and the burden to the patients as well.